All right, so I'm going to spend the next 6 minutes talking about the management of spontaneous CSF leaks. These are my disclosures. None of them are relevant to this discussion. So what I'd like to talk about is this this etiology of spontaneous CSF leaks and some of the physical findings that are associated with elevated intracranial pressures, and talk about some of the pros and cons of the treatment of this potential elevated intracranial pressure playing a role. So as you can see, it's a relatively small percentage, but it's the one group of CSF leaks that may have some ability to modulate the success of your repair based on what you do afterwards in terms of repairing them. So, over the last 15 or 20 years now, the publications when you go and read about spontaneous CSF leaks, they've been linked to an etiology of potentially elevated intracranial pressures. And initially it was because several patients with known elevated intracranial pressures would then develop a spontaneous CSF leak. And then when patients started looking, or when physicians started looking at the commonalities of these two diseases and found that there was a lot of similarities, such as the demographics, commonly affecting middle-aged women that were obese, with some of the similar symptomatology. So many of the patients might describe pulsatile tinnitus, headaches, as well as on MRI findings or CT findings, evidence of a partial, complete empty sella in both of these groups. And so therefore, a lot of people started looking at this, and in fact, there's data that suggests that the hormones of female hormones and adipose tissue can contribute to cause an elevated intracranial pressures by decreasing the drainage of CSF as well as increasing the production. And you would think then the idea is that over time, this elevated pressure would then result into a potential spontaneous CSF leak. The issue, though, is that when you look at the literature, you would think that that makes sense, and that you would expect elevated intracranial pressures in all of our patients with spontaneous CSF leaks. But it's very difficult, as you can imagine, to measure pressures in someone who's actively leaking. So it's hard to make that relationship. And in fact, only a small percentage of patients with elevated intracranial pressures actually develop a spontaneous CSF leak. So the argument is that there's probably other risk factors that are associated with developing a spontaneous CSF leak. And why does it matter? Well, when we go to repair CSF, our success rates have been overall very well, and reported to somewhere now in the 84 to 97 percentile in the last 5 to 10 years. But it's this group of spontaneous CSF leak patients that are generally in this lower success rate, in the 80 percentile range. And this prompts the question is maybe there's something we should be doing other than what we're doing in the repair process, but maybe the after care of these patients. And this was really highlighted in this paper by Atici et al. In laryngoscope about 2 years ago, where they looked and did a meta-analysis and combined it with their own 100 or so patients to see whether or not, if you did actively manage the pressures in patients after the repair, could you have differences in success rate? And in fact, what they found is that in patients who had intervention for elevated intracranial pressures, whether that's acetazolamide or shunting, then the success rate was significantly higher than those who did not have active intervention for elevated intracranial pressures. So what are our options for managing this elevated pressures, should they be there? Well, there's 3 of them: weight loss, acetazolamide, and VP shunting. VP shunting is obviously very invasive, so I'm not going to talk about that because that only happens in a very small group of patients. But there's 2 of them, acetazolamide and weight loss, that we can rely on. And interesting enough, there's not a lot of studies or papers that talk about weight loss and the ability to have increased success in our CSF repair. However, if you look at the literature for elevated intracranial pressures, a small weight loss, 3%, as low as 3%, so that's 3 pounds in someone who's 100 pounds or 6 pounds in someone who's 200 pounds, can decrease noticeably intracranial pressures as well as improve papilledema. So that's something that maybe we should consider. But the most common one is acetazolamide. It's a carbon anhydrase inhibitor, and it functions by decreasing the rates that we make CSF fluid. And typically the dosing that we recommend for our patients would be somewhere between 250 to 500 milligrams BID. The problem is that this drug is not without side effects. So many of the patients that I've put on acetazolamide will complain of feeling very fatigued, paresthesias in their fingers or in their toes, anorexia, not wanting to eat, and electrolyte changes, so therefore you have to check their electrolytes on a regular basis. And so what's interesting is that initially when reading this literature, after any patients who show up with a spontaneous CSF leak, I routinely would put them on acetazolamide. But then I started having some of these patients tell me about their side effects, and then it was interesting that I would put them on and I would send them to the ophthalmologist or to the neurologist to manage it, and a lot of the patients, they ended up taking them off of acetazolamide. So who should you consider starting on postoperative acetazolamide? Well, I think that there is some data that links these two diseases together, but obviously there's other risk factors that are associated. So I only now put them on the patients who have signs of postoperative symptoms with elevated intracranial pressure. So if they develop pulsatile tinnitus, if they show papilledema preoperatively, those are the ones that I put on acetazolamide and then refer to the neurologist to continue managing it. I usually only keep them on for 3 to 6 months, with also stressing the importance of weight loss goals. And I usually do about 250 BID and maybe need to titrate up to 500 as necessary. And of course, we have to check their electrolytes every 4 to 6 weeks. I just want to highlight real quickly this interesting article that just came out in 2019, where the group, Payne's group, Spencer Payne, has started putting them on preoperatively. And they found that 5 out of 16 patients that they put acetazolamide on in patients who had spontaneous CSF leaks actually did not require surgical repair and stopped leaking within the month of utilization. Now, there's obviously a lot of controversy about this, but it does highlight that maybe there's a significant group of patients that probably elevated intracranial pressures is not the sole cause of the CSF leak, but there's probably more to come from that. So in conclusion, the clinical presentation are very similar in these two populations. However, I suggest that it's not just elevated intracranial pressures, and if you read the literature, you would think that you should put all of your patients on some sort of medication to decrease intracranial pressures, but that might not necessarily be the case. And so there's more to do in this field, but maybe looking for specific symptoms that would be more supportive of that, rather than just blanketly treating everyone on some sort of intracranial pressure intervention. Thank you.